It's noon, so thank you everyone for coming to my grand rounds, which is actually the last grand rounds for me this year, the only one. So I decided to talk about SGLT2 inhibitors in kidney transplant as well as CKD. As I told you, there is, first of all, limited data in kidney transplants. However, that's why I decided to do it as a timeline. I'm not here to teach anyone who's more expert than me on SGLT2. I just decided to take a step back and look how this medication, which is almost the closest thing to magic nowadays to nephrologists as well as cardiologists, how it evolved over time and why do we have this medication and using it. Last clinic yesterday, I did my own observational cohort, and I was counting how many times I would hear SGLT2, Farxiga, Jardiance, and I counted more than 12 times within the sake of 2 hours. So we're using it a lot. So let's step back and see how we're doing with that. All right, no disclosures. So as I told you, my point is to try to go backward, look at the evolution of SGLT2 from the beginning, and then try to touch base a little bit about the physiological mechanisms, how SGLT2 works, and have a quick look as we go through this timeline on the landmark trials that happened in the native CKD, and then eventually look at what has been done eventually in kidney transplant patients. So it started with Appelmark. Actually, going back to the 1835, they discovered it in Peterson, which is a French chemist. They discovered fluorescein, which was when he was boiling apple bark to try to find actually a treatment for malaria and fever. He didn't know that it's going to be a big evolution. And 50 years went by, and then the kidney, Dr. Joseph von Mering, which is a German physician, actually found out that this medication, he was doing some investigations on dogs, and he incidentally noticed that they are dumping a lot of sugar in their urine when giving them fluorescein. So things passed by, and they were trying to solve the puzzle. Between 1930 to 1980, they were able to identify the, mapping the proximal tubule in, and also Dr. Robert Crane at that time had a major impact on identifying the sodium glucose co-transport mechanism. The problem at that time that this fluorescein was non-selective. It was affecting SGLT2-1 as well as SGLT2, so it was causing a lot of diarrhea. And the other thing is that it had poor oral absorption. So they couldn't, because of the glucosidase enzyme, like bacteria-releasing glucosidase in the intestine, so it had to be given IV. So time passed by, and then in the 1990s, pharmaceutical companies were trying to get some analogs that are more stable. And eventually in 2008 was the breakthrough when they were able to give an oral dose once daily medication. But it wasn't until 2013 to 2015 when it was FDA approved, and that was for diabetes, and that's like the glucose ale. I'm going to touch base a little bit about the rosiglitazone effect in later slide, because that was the trigger point to start all these studies, basically, to reach the cardio-renal protection that we have now. So as I said, when they FDA approved, they initially approved canagliflozin in 2013, which had the lowest selectivity for SGLT2. And then 1 year later, they approved dapagliflozin as well as empagliflozin, which had the highest selectivity. At the time, it was only approved for type 2 diabetes. At that time, the main mechanism that was thought is basically glucose-lowering drugs. They thought that it is actually inhibiting the sodium glucose co-transporter 2 in the proximal tubule, blocking 90% of glucose absorption, causing almost 30 to 80, anywhere between that, grams of glucose excretion in the urine, and it had modest glycemic effect. A1C was reduced by 0.5 to 1. The rosiglitazone is one of the older diabetic medications, and the problem with that medication is that they were doing some meta-analysis on it, and in 2007 they actually had a meta-analysis which changed the field. At the time, they found that there is an increased risk of myocardial infarction by 43%. A medication that's supposed to treat diabetes was actually causing more MIs. So that's when the FDA panicked, and 1 year later, they started this mandatory regulation asking for cardiovascular outcome trials for each new diabetes medication that before being approved. So things exploded since 2013. As you can see, a lot of tests. Initially, they were trying just to prove that their medication is basically a safe diabetes medication that's not causing MI like rosiglitazone. But then they incidentally found things that we're going to talk about. And as you can see, the SGLT2 inhibitor in pink, those are the studies that have been done over the past few years, 10 years. This is the first trial that was done. EMPIRIC was in 2015. Now, most of the studies actually were published in New England Journal of Medicine. And as I told you, this is the first cardiovascular outcome. They took empagliflozin and randomized it with placebo. They looked at 7,000 and followed them for 3.1 years. They were trying to see, just the safety of the medication. However, eyes were wide open when they saw, we physicians love Kaplan-Meier curves when they start separating. So they saw this and they were like, oh my God, there is like almost 14% relative risk reduction. They used 3-point MACE for most of these studies, which is cardiovascular death, non-fatal MI, or non-fatal stroke. And they actually found some key secondary outcomes that they were just investigating. And they found, I'm not going to bombard you with the numbers because nobody's going to remember those numbers, but just saying that it was significant reduction in cardiovascular mortality, heart failure, and unexpectedly, they looked at the GFR and they saw a slower progression of kidney disease. So this is what they saw, the incident or worsening nephropathy. So at the time, they decided to do a post hoc analysis looking at different renal outcomes, 7 of them. And what they noticed is that there is a significant reduction in all of those, including doubling of creatinine, 44% reduction in the EMPA people, macroalbuminuria, or what we call nowadays severely increased albuminuria, and the incidence of starting renal replacement, more than 50% reduction. This was the first spark that this medication could save some kidneys. So later, canagliflozin actually became jealous that why EMPA is the only one. So they decided to do their own study. And in 2017, they took more people. They used canagliflozin versus placebo and followed for 2.4 years. They saw the same thing. And that started saying that, oh, this is a class effect rather than just a one medication thing. And they found a similar relative risk reduction in the 3-point MACE. They looked at albuminuria and they looked at composite of 40% reduction in GFR, renal replacement therapy, or death from renal causes. And they found 28% reduction and 40% reduction in the composite renal outcome. So significant numbers were coming. However, in Canvas study, the drawback was that they found two important safety signals. There was an increased risk of amputation risk, especially in the toe or metatarsal, and the fracture risk, which was numerically higher but not statistically significant. Who is left? Dapagliflozin. So they did their study. They decided to have the largest trial, and those were less than 10,000. Those took more than 17,000. And they decided also to take not only type 2 diabetes with established cardiovascular, they also looked at people who are at risk of atherosclerotic cardiovascular disease. And they followed them 4.2 years, giving them dapagliflozin versus placebo. Now, they did not, like the other two studies, found a significant difference in MACE. However, they did find a significant difference in cardiovascular death or hospitalization for heart failure. If you read the story, they basically, or the article, they basically claim that because the MACE reduction wasn't statistically significant because the population they had might reflect lower risk population because they took people with less established atherosclerotic disease. So similar findings, they looked at renal composite, and as you can see, there is like almost 24% risk reduction. So at that time, kidney benefits were still considered secondary or exploratory findings. So that's when, in 2019, credence came. Canagliflozin decided to do the first trial for just primary renal outcome. So what they did, actually, they took 4,400 participants. They took patients with type 2 diabetes, CKD people with a lower GFR down to 30 up to 90, and with macroalbuminuria with an ACR of more than 300. This study was stopped early for efficacy. They only had to follow them before 2.6 years. What did it show? Now, the composite primary renal outcome that they looked at was actually developing end-stage renal disease, doubling of serum creatinine, or cardiovascular death. And that's what they saw. They actually saw almost 30% risk reduction in the primary composite outcome, which was purely renal. Notice that in this study, all of them were on ACE and ARB. So whatever benefit they noticed was actually additive benefit beyond the RAS blockade. And when they looked at subgroup analysis, they found that even people with a lower GFR category had also significant improvement and had larger absolute benefits. They also looked at ACR, and they found this persistent reduction in the urine albumin to creatinine ratio. And then they noticed this dip in GFR, where it goes by almost 5 points of GFR. However, that stabilized over time, and the rate of progression when they followed it for like 42 months was slower. This acute GFR dip, initially there was a concern, is it an AKI or no? But when we're going to talk about how the hemodynamics change, that's where we're going to explain things or like touch base on things. They found that there is a decline of 2 to 5 points. The predictors, like they noticed that they are more pronounced with people with lower baseline GFR or higher albuminuria and people who are already on diuretic use. The tolerance threshold that they were able to agree on is that as long as the increase in the creatinine or the decrease in the GFR is less than 30%, this should be safe and should not prompt discontinuation as long as we see recovery and slower progression after all. And this is largely reversible upon drug cessation. And they saw that there is a long-term benefit even in patients who experienced the GFR dip, they still derive full cardiorenal benefit. So what did this article change in our practice? It actually was the leading cause why FDA approved this SGLT2 for diabetic kidney disease. Now, I know you're bored with the many studies that I presented so far, so I'm just gonna give a break and talk about a little bit like why they were doing those tests and studies. They were also doing physiological studies to know how those medications, which cause a modest reduction in A1C, are causing all this magic with the cardiac and the renal protection. So, I mean, they were approved in diabetic kidney diseases. So looking at the diabetic hyperfiltering kidneys as an example, you can see that there is a lot of sugar being dumped in the urine, and there is SGLT2 in the proximal tubule, which is absorbing more glucose and as well as sodium. So that will lead to basically decreased distal delivery of sodium when it reaches the macula densa, which is the sensor. That's where it basically interprets this as decreased effective circulatory volume and causes some adenosine signaling to cause afferent vasodilation. And that in turn will lead to the increased intraglomerular pressure and hyperfiltration, which can damage the kidney on the long run. So what SGLT2 they were able to prove is that it was able to restore this tubuloglomerular feedback back again. So you're giving an SGLT2 inhibitor, you're increasing the glucosuria as well as the natriuresis, more sodium is reaching the macula densa, and that's basically causing adenosine signaling to cause vasoconstriction. and lower intraglomerular pressure and lower hyperfiltration on the long run. Also, at the same time, renin is basically RAS activity is increased, and that would cause the vasodilation, or actually, like RAS is inhibited, so it causes vasodilation. But that's not only it. When they studied, they found that there are multiple benefits beyond hemodynamics, including pleiotropic effects. This is a nice, figure I found in here's pink. So basically, it shows the different ways that SGLT2 can work. So just going over, few of them, by doing natriuresis and glucosuria. Natriuresis will eventually lead to decreased plasma volume, which will decrease myocardial stretch, and that's why the arrhythmias are less. And at the same time, sympathetic nervous system on the long run is less, and that will lead to the cardiac renal protection. That's one part of it. The TGF that we talked about is also another part of it. Natriuresis will decrease blood pressure, and that will cause decreased arterial stiffness. So you can see the multiple things that SGLT2 is affecting. Glycosuria by itself will cause a modest reduction in A1C. However, the more important is that it decreases glucose toxicity. So that's why there is less inflammation, which affects cardiorenal protection on the long run. Hyperuricemia, they have found that there is increased uric acid excretion, which might have some effect on decreased atherosclerosis. And then because of the glycosuria and losing glucose, the body shifts to ketone metabolism more and fat oxidation, and that puts the patient in a negative caloric balance. That's why the fat might decrease in the body, and that might cause some weight loss, as well as the SGLT2, they found that it decreases the inflammatory and the fibrosis markers. So that's basically just the break about the mechanism of action. Now, going back to DAPA-CKD, this is the second renal outcome. What is unique about this study is that the first study took up to 30 GFR. They decided to go lower to GFR 25, and they decided to lower the threshold of the proteinuria to 200. And they not only did that, they actually, in the first study, they only studied diabetic kidney disease. Those people decided to include 1/3 of their cohort without diabetes, meaning that they have like hypertension nephropathy or IgA or so on. And they looked at kidney and cardiovascular outcome, as you can see. And what they saw is just a similar Kaplan-Meier curve. There is separation within the first few months. There is 39% relative risk reduction in the primary composite outcome. And in the renal specific, it's almost 44% relative risk reduction. Now, the only point I'm trying to prove here is that when they did a subgroup analysis, they looked at people who did not have type 2 diabetes, and they still found a significant reduction in those outcomes, even though those patients are not diabetic. So that changed our paradigm from using it and FDA approved for diabetic kidney disease to actually now looking at it as a kidney protective agent independent of diabetes status. Then, the last one, EMPA came and they asked, like, how much more can we push the boundaries and how late in the CKD process can we do this? So they basically looked at, 6,600 people, they randomized them and followed them for 2 years. The unique feature is that they went as low as 20 in the GFR. They had a larger cohort without diabetes, more than half of them. And they were including people, especially the lower GFR people, with even no albuminuria or less than 30, meaning that they were testing it on non-albuminic CKD. And no surprise, you're seeing the same Kaplan-Meier curves, and that was also proved by this study. They decreased the kidney disease progression and cardiovascular death by 28%. When they looked at the subgroup analysis, what I want to emphasize here is that even the people with advanced CKD, less than 30, they did have statistically significant improvement and reduction in the composite outcomes. In this study, they didn't really find a significant reduction in people who had no proteinuria, less than 30 or 30 to 300. However, it's not attached here, but there was a follow-up study published, I think, in The Lancet. It was in like 1 year or 2 years later, and that showed that even this subgroup had actually slower progression in the slope of the decline in the GFR.
Yes, that was an estimation, I think.
Estimation.
Meaning that if the trials were continued over
Then
the years,
it would.
we estimate that it could be beneficial.
Yes.
I'm just making sure.
So what was the follow-up time of this particular study?
This one,
Yeah.
they followed just for 2.6 years, I
years,
think,
yeah.
because it was stopped early for efficacy.
So that's what the
Yeah.
estimating say.
Yes.
Prolong it
Yes.
for 5
They
years.
didn't want to,
maybe.
Maybe.
We did a co-op studies too, right, in large cohorts. We presented that before the journal.
For a longer period.
Longer period plus eating a GLP-1 on top of that in some patients and what happens. Sorry.
No, you're good. So the practice change, this is basically they lowered the GFR that we start SGLT2 for, and now it's down to a GFR of 20 that we feel safe about starting. And even in patients without significant proteinuria in advanced CKD, some might also benefit. So that brings us to KDIGO. What does KDIGO say about SGLT2 use in CKD? So there is a consensus between ADA and KDIGO 2022 diabetes in CKD guideline, the management guideline, and that updated the recommendations to include SGLT2 for type 2 diabetes and CKD with a GFR of 20 with the highest grade recommendation of 1A. And that's regardless of A1C, regardless of glycemic target, and that's in addition to the metformin and other glucose lowering agents. The last update from CKD guidelines, KDIGO 2024, they also have the same recommendation, grade 1A, to recommend SGLT2 for CKD and GFR of more than 20, regardless of diabetes or albuminuria status. So I think we're good on time. So SGLT2 actually revolutionized the native CKD management and cardiorenal care. And there is strong evidence that you saw for mortality, cardiovascular, and kidney benefits. But what about kidney transplant patients? So just to put some key points about the kidney transplant patients populations, those people have unmet needs. Those people have cardiovascular disease as the leading cause of death. And if this medication protects, then why not use it in them? They have progressive allograft function, and they have high diabetes prevalence because of the chronic immunosuppression they are on, including CNIs and steroids. So it's almost in some studies up to 40% of PTDM developing in those patients. The theoretical benefits, as you can see, if we are able, those patients have a single kidney, they are hyperfiltering. If we are able to increase the intraglomerular pressure in a single hyperfiltering kidney, that will hopefully, theoretically, apply to this population and cause cardiovascular protection, glycemic control, and weight reduction. However, unfortunately, appropriately so, kidney transplant recipients were excluded from all the previous articles and the studies that I told you about. And that created a significant evidence gap for any formal recommendations. And the main concern is because those patients are immunosuppressed, there is a risk of UTI, genital mycosis, and drug-drug interaction. Are they affecting CNI, and would they increase the risk of AKI or rejection risk? So what does KDIGO say about kidney transplant patients? Right now, as of 2022, the ADA mentioned the KDIGO consensus for diabetic management. They said that they explicitly excluded kidney transplant from SGLT2 recommendation because the safety and efficacy is not established. And they know that SGLT2 are promising, but without randomized controlled trials, don't talk to me. So KDIGO 2024 CKD guidelines they closed their ears and they said we don't have any recommendations until more studies are there. This is in 2024. What I'm about to show you is those are before the observational evidence that has been published more recently within the last 2 years. So just to go back and do some comparison between a native kidney and a transplant kidney, we know that there is a difference in the nephron mass. We have a single kidney in allograft. Those patients, when we take the kidney out, they are surgically denervated, so they don't have any sympathetic innervation, and they are pharmacologically immunosuppressed. However, as I said, like the leading cause of death in both categories of patients is cardiovascular disease. So the questions and the concern that come to mind is there an increased risk of AKI with giving SGLT2 to transplant patients? Do we see the initial GFR dip just like we do see in the native kidneys? And the TGF, I mean, it is a paracrine, but there is also control with the sympathetic nervous system. Without the sympathetic nervous system, will there be like a TGF restoration? And then those patients, especially in the beginning, they are very sensitive to volume. They have a lot of hemodynamic changes. So are they going to respond as, the same as the native kidneys, especially they do not have sympathetic nervous system connected to their kidneys? And then eventually the increased infection risk. And those patients have like no valve when they connect the ureter to the bladder. So there is easier risk of infection, ascending infection and causing pyelonephritis. And then the drug-drug interactions, are they causing any change in the CNI and increasing the risk of rejection? If you look at the immunosuppression they take, each side effect of immunosuppression can be partly, helped with SGLT2, whether it's from electrolyte and uric acid dysregulation, which I'm going to come, at a later time to, uric acid reduction, increased magnesium level. We suffer from those hypermagnesemia a lot because of the CNIs, especially in the beginning. Hypertension, most of the medications have those side effects, and we can help with natriuresis and decreased blood pressure. Weight gain, it has shown some weight loss effect. Adipose, weight obesity, basically, there is improved fat oxidation using SGLT2. And then glycemic control, it might help a little bit. And then cardiovascular risk factor. So you can see that it can target multiple side effects of those immunosuppression medications. So the current evidence in transplant patients, I'll tell you honestly, it's not like a whole lot. There is no big randomized control trials that I presented to you with native kidneys. There are only 2 small randomized control trials so far done. I divided them into 3 phases that I'm going to talk to you about. Phase 1, they started in 2017. They looked at small safety pilot studies, case series here, case series there, to try just to prove the safety and the efficacy of those medications in specifically diabetic kidney transplant patients, whether it's type 2 or post-transplant diabetes mellitus. The 2 randomized control trials I'm going to talk about, but most of those studies have less than 1 year of follow-up. The second phase, when they collected a good number of those small studies, they also started doing more observational propensity score match studies on a larger number of patients. And then more recently, they started doing meta-analysis on those studies to have, the best evidence that we have when we don't have randomized control trials. And in that phase, they moved from trying to prove the safety and efficacy to see if there is any cardiovascular and mortality benefits in this subtype of group of patients. And phase 3, which actively is ongoing, there is some randomized control RCTs going on that I'm gonna talk about. So Holden and colleagues in 2019, they did the first randomized control trial. They took 44 kidney transplant patients. However, as you can imagine, they were afraid of doing it on an early transplant. They took a stable patient, meaning that transplant was more than 1 year. Their GFR was more than 30, and it was stable within the last 2 months, meaning that they had less than 20% deviation in serum creatinine. They had to have stable immunosuppression for 3 months and diagnosed with post-transplant diabetes. You can see that most, the median population, actually they started it after 3 years with a decent GFR of 59, not a bad A1C, 6.9, and they followed up them for 24 weeks while randomizing them on empagliflozin 10 milligram versus daily placebo. What they have found is basically they found a significant reduction of A1C. It's a modest reduction, 0.2, just like in the native kidneys, compared to increase of 0.1 in the placebo. They did find a modest reduction, but was statistically significant of 2.5 kilogram loss compared to 1 kilogram gain in the placebo. And then they did not really find significant differences in blood pressure, in GFR, although I'm going to talk about the initial that they noticed, or immunosuppressive medications. So safety, which was everyone was like, hesitant about, actually they did not really find a big difference. There were 3 UTI in each group. 2 withdrew from the EMPA because of UTI, and 1 case developed sepsis. And genital yeast infection happened only in 1 patient in the empagliflozin. That's a small study, so take it with a grain of salt. But this pioneering study, at least this is the first we have in kidney transplant, showed that those medications can be safe and effective for glycemic control, as well as they might help with weight reduction without affecting CNI majorly or affecting UTI risk. The second randomized control trial, this was actually done more recently. And this was more of a mechanistic study. They had a double-blinded, placebo-controlled, randomized control trial. They had only 52 kidney transplant patients with and without type 2 diabetes. In this study, they were not trying to prove that this medication has a cardiovascular benefit or so on. They were trying to see the physiology of the kidney, how it acts when we give it SGLT2. So they randomized people, dapagliflozin 10 milligram versus placebo for 12 weeks, and they looked at the change in seated systolic blood pressure. So what they have found is actually, now I'll talk about, the systolic blood pressure. They didn't really have a significant reduction. So they failed to meet their primary outcome. And there was theories about why. And one of those is basically the compensatory mechanisms that happen after a while, as well as the CNI basically causing increased sodium retention. So whatever you're causing natriuresis, you're absorbing back with the CNI being given. And because the sympathetic nervous system is not connected to those kidneys, so there is not really autonomic effect on those. They did kind of like, it's a weird study, like they did like admit them, gave them, and used lithium actually to look at the sodium handling in the proximal tubule. So they would give them like lithium carbonate 300 milligram the night before, and then look at the fraction excretion of lithium the next day. They admitted them to the hospital to keep their sugars under control within 70 to 110. They put them on IV insulin and IV glucose as needed to make sure that there is no hyperglycemia in the blood affecting the numbers. And what they have found is that there is no change in the proximal sodium handling or the sympathetic activation. So they also used the measure iohexol GFR to look how much it declines. And they found that there is a decline of 4.2 at 1 week and a statistically significant decline of 3.49 at 12 weeks. So similar to the native kidneys that we see, despite those kidneys being denervated. And they also looked at secondary outcomes, basically just looked at the risk of UTIs and the safety. There was not really a significant impact on tacrolimus, increased risk of AKI or rejection.
For lithium, they gave the lithium.
Yes.
I'm not sure if they had access or not, but you don't have to give lithium. So if you have sensitive enough technology, which is ICP-MS, which mass spectrometry, you can use native body lithium to calculate the fractional excitation of lithium, which is in nanograms in urine.
I don't know if they had that technology, but yeah. But
we have it at UF. I'm just saying. So
are you sure they give lithium?
Yes. Lithium carbonate 300 milligram the night before.
Okay. Because it's much easier. You just
technically you're afraid to give someone lithium. It was like
they use lithium in direct resistance to acute heart failure, but they don't give lithium as Dr. mentioned.
Like they
just use the.
Okay.
How far were these patients after transplant? They were stable. They were also.
Yes, those patients were like age of like 56, more than like at least 1 year after transplant. Like 50%, 62% were hypertensive, 50% of them were on RAS, and like 57% were diabetic. But all of that, they didn't touch any transplant patient that I saw less than 1 year in any of the studies, observational or random. I mean, those are the only 2 randomized controlled trials. I didn't find any more. So Physiology is good, but we always want to see survival curves. So that's when phase 2 came, and they started looking at more observational data. There are 4 major cohorts that I want to talk to you about. Lim et al. In 2022, and then they followed, the same group followed in 2024. Fructoso, and I'll come to this why I included it in my band rounds, and Shu, which they used the largest cohort. And then that was followed by this, which was released. This is the largest and the most recent meta-analysis of using SGLT2, not only not only SGLT2, sorry, but also GLP-1 receptor agonist in kidney transplantation. So the first cohort they did, Lam et al., they did a multicenter retrospective cohort. They included 6 people in Korea. They looked at 2,000 diabetic recipients with 226 that were on SGLT2. So that has like 10.8% of the cohort they studied. Now, they don't have a randomized control trial, so the best they can do is trying to do a propensity score matching. They tried to match patients between SGLT2 and the other non-SGLT2 group in terms of age, sex, BMI, the donor type, whether it's live or diseased donor, baseline kidney function, A1C, and metformin usage. And the primary outcome was significant. It showed 57% reduction in the composite outcome, which they looked at all-cause mortality. They looked at death-censored graft failure and creatinine doubling. So you can see, here we are again with like divergence in the SGLT2 versus non-SGLT2. Now, secondary outcomes, they did not really find a significant difference in GFR or A1C, and no really significant difference in UTIs or even zero DKAs in any of the people they looked at.
Just for education purposes, and I'm sure Dr. Shukla or Dr. Canales will know more about it, but the problem with this observational study when you don't have a target trial emulation or new user design, it comes with survival bias, which is people who are long-term exposed on SGLT2 inhibitor. Even if you do the propensity score matching of 7 parameters,
it's not gonna remove the confounding
negative study on it.
Yes.
Just for the fellows education purposes.
Yes.
So before you start, it's going to be positive study. I'm just saying.
That's the best we have so far.
Doesn't mean it's not beneficial.
Yes.
I don't mean to pass that message. I'm just saying the criticism of it in general.
Taken, yes.
Issa?
Okay. Yes.
Did they use the group analysis for survival curves for AMPA versus DAPA?
Not to my knowledge, but I can go back and double check. But I didn't see like there was like a subgroup or like just EMPA, because EMPA 66, DAPA 33, but yes. I can definitely come back to you, but not to my knowledge that they did this. Then the second part they looked at this study is actually they looked at the initial GFR dip, and they defined it as more than 10% drop in the GFR within the first month. And they found that in the transplant population, only 15.6% were really dippers. And they followed them over like 10 months or so. And they found that almost by month 5, their GFR dip will recover completely and stabilize afterwards, just like they do in native kidneys. And what is, they identified like significant risk factors. They said that basically when they looked at subgroups, they saw that people who started earlier, the SGLT2, now, this is 397, so more than like within the first year, basically, or year and few months, they are more at risk of having the GFR dip. And people who have higher tacrolimus level, and they defined it as more than 7.5, which, physiologically makes sense because those patients are like having synergistic effect of vasoconstriction on the afferent arteriole. Now, the same group, Lim and colleagues, followed this up in 2024, and they published in KI reports. The aim of this study was to look at the cardiovascular mortality. And they did the same, design of the study, propensity score matching, 127 that were on the control group and 127 that were receiving SGLT2. And they found that there is a lower incidence of MACE. Now, you can see basically that the lower incidence of MI and lower incidence of death. Fructoso, I decided this is a study I decided to share because it has some unique findings. It's a smaller study. It was done in Spain. They looked at 339. It was like an observational multi-center studies. They looked at people who had SGLT2 for 6 months and looked at the adverse events. Now, they found, contrary to what I'm going to show you, that there was significant risk of adverse events, 26%. 14% of them were UTIs, and actually 10% had to be withdrawn because of this. But they were able to identify a specific subgroup of people who are more at risk of developing those UTIs. They found that the odds ratio of having a prior UTI within the last 6 months makes the patient 8 times more likely to develop a UTI, and the female gender, which makes sense because of the shorter anatomical, like urethra and so on. Secondary outcomes, I mean, I'm going to talk more about them in the meta-analysis, but that's why they use the multivariate analysis to allow this risk stratification. Then Shu et al., basically they used the largest TriNetX global database. This is a massive federated health research network that looks at EMR records worldwide. So basically, they looked at transplant population, kidney transplant, type 2 diabetes between June 2015 and 2023. And they were able to collect almost 4,000 patients divided between the SGLT2 users and propensity score matched non-users. And they followed them for looked at a total of 3.4 years. Now, as you can see, the observational evidence they saw in this study was that SGLT2 actually increased all-cause mortality by a significant number. We're talking about like almost 68%. Now, take it with a grain of salt. We're not talking randomized controlled trials, but this is what they found. And the MACE was 52, and the MAKE, major adverse kidney events, were also almost 50%. Now, the magnitude is remarkable, and that's also what reflects some residual confounding, despite trying to mimic a randomized controlled trial with a propensity matching, as Dr. Shah said. So one interesting thing, I learned new is like doing this methodology of a negative outcome control and using like appendicitis rate just to see if there is an effect or no. And they use it didn't show any association with the negative outcome. And there was no significant difference in the UTI or AKI in this cohort of population.
Actually, that tells for a good observational study.
Yes.
When you have good negative
outcome, control outcome. Yes,
that's all you got, unless you do target trial evaluation, which makes the introduction for these adaptation class proposals. What I was trying to say is, if you want to make something better out of it, I think that's why it went into Nature, to have even all the biases, but you have a negative control,
the negative outcome,
which is a better way to do an
They had
observation.
multiple, right? They didn't have one. They had
so.
multiple. The whole lineup here.
Yeah.
Right? Irritable bowel syndrome.
That's why you need a number is important in observational study.
In
You
observation.
can't do the so many negative.
That's
unless
what
you
they
have
had
larger sample size.
Yeah, they had a good number because they went back to the TriNetX. But yes.
Hematological cancer. Really.
Yeah, I looked. They do like appendicitis here, vitamin C level here. So yeah. Okay. Anyways, I think we're good on timing so much. So, the meta-analysis by Lee, which was the most recent evidence, and this was published just late 25, early 2026. They analyzed 32 studies, and they looked at a total of almost 8,000 patients. They included 21 studies on SGLT2 and 12 on GLP-1 agonists. What they concluded is that basically that the impacts on mortality, cardiovascular, and kidney outcomes, they confirmed significantly lower rates of all-cause mortality, MACE, and MAKE across large matched studies. They looked at impacts on renal outcomes, and all these studies, they did not really find any decline in kidney function. It was stable in the GFR. Proteinuria-wise, they did not really find a significant difference in proteinuria. And their explanation of this discrepancy is that because they are claiming that most of those transplant patients that were included didn't really have a big proteinuria or significant proteinuria to start with, and that limited the statistical power to detect a meaningful impact on proteinuria, and using it but further studies might show different results. They looked at metabolic surrogate outcomes, and BMI, they were able to find a significant weight loss of 2.2 kilograms. A1C, a significant or statistically significant reduction of 0.3%. They also looked at magnesium and uric acid because those are important things we face in transplant population with the side effects of the immunosuppression. And they did found, although it's a modest effect, 0.11, but it is a significant increase. I actually went, in the literature and tried to see how much in native kidney disease it has been shown to affect magnesium. Correct me if I'm wrong, Dr. Shah, but it's 0.3 up to 0.3 maybe or so. I don't know.
Without placebo control, 0.3.
0.3.
But if you use placebo control, because in placebo also it goes up.
Yeah.
So, because people are under
So it might be even lower.
So 0.2 was the meta-analysis of the randomized control trial compared to placebo.
To placebo, yes.
0.2. 0.1 here is questionable because do you have a control arm here? You don't have a control arm. So CNI patients may have in a control arm is minus 0.1 possibly.
Yes, it might be even
plus
lower.
0.1.
Yes,
actually
so
it
it might not
be
have,
0.2.
Yeah,
Possible. The delta is hard to guess without a control arm.
Yeah, I mean, we're giving magnesium nowadays. We're not prescribing SGLT2 for helping with hypermagnesiemia in transplant patients. And the uric acid, they found significant reduction of 0.62. And they found more, reduction in people who already had hyperuricemia as a side effect. Safety-wise, this meta-analysis didn't really find any increased risk of infection, no significant interaction with immunosuppression, and calcium urine inhibitors remained relatively stable, and no increased risk of graft rejection. And this was, I like infographics, that's why I added it. So, phase 3, which is now ongoing, there are few things that I was able to pull up, and they are ongoing, so I don't have the results yet. But one of the largest is actually the renal life cycle, which is ongoing, and it should be completed in 2027. This is not only for kidney transplant. They're using 15,000 patients, but they included kidney transplants with a GFR of less than 45, but they have to be at least 6 months out of the transplant, and they are using on them dapagliflozin 10 milligram compared to placebo, and they're looking at all-cause mortality, kidney failure, and heart failure hospitalization, trying to mimic the studies that were done in the native kidney disease. Most of them are done by dapagliflozin, and they're, here they're looking at SGLT-GFR, 88 patients with non-diabetic kidney transplant. They're looking at the GFR slope, and they're still recruiting. DAPA transplant, 330 kidney transplants, still ongoing. So we have a good number of studies that are ongoing, and we might have good data by that time. Now, it's not as much as the native kidney disease. There is also CREST kidney transplant. They're using empagliflozin, and they're looking at changes in albuminuria, cardiac structure using MRI, and insulin levels. And lastly, there is the hallmark study, but that is not only using SGLT2, but also GLP-1 for people with and without diabetes. So, until such trials are completed and we have randomized control trials, I think at this point, we do use SGLT2s in the clinic as long as the patient is stable, and most of our data is supported by extrapolation of this data from the native kidney disease, as well as those observational data that are the best we have so far. So this is what we have. In summary, native CKD, we talked about how SGLT2 became, closest thing to magic for a nephrologist as well as cardiologist. Nephroprotective mechanisms extend not beyond the A1C lowering effect, but it also has hemodynamic, affecting the TGF as well as pleiotropic effects. And in kidney transplant, right now the KDIGO guideline exclude kidney transplant from SGLT2 recommendations. We noticed how there was a GFR dip in 15.6%, and that usually recovers by month 5. And the predictors for that is more recent transplant and higher tacrolimus level. Observational studies are telling us that there might be the same benefit in kidney transplant patients. We just need to do more studies to prove it. And some randomized controlled trial data are on the way. And with that, I think I finish. Thanks.